Okay, good morning. Welcome, Your Excellencies, distinguished delegates, esteemed colleagues, honored guests, ladies and gentlemen. Good afternoon or good morning, good evening to some of you from wherever you're calling it from. My name is Arik Shimmick, and I have the honor of serving as the Assistant Director of Advocacy for the Center for Global Pediatric Health, a partnership between the Anne and Robert H. Lurie Children's Hospital of Chicago and Northwestern University's Feinberg School of Medicine. It's my pleasure to welcome you to today's United Nations High-Level Political Forum event, Accelerating Hepatitis Elimination, Closing Gaps Through Policy and Partnerships. Thank you for joining us from around the world today. We're honored to welcome representatives from United Nations agencies, government ministries, academia, healthcare systems, civil society, and the global health community. Your presence reflects our shared commitment to advancing health through collaboration, innovation, and action. Before we begin, just a few housekeeping notes to share. All attendees will remain muted to ensure the best audio quality. We encourage you to submit your questions throughout the program using the Q&A feature at the bottom of your Zoom screen. We'll reserve time for discussion at the end of today's session. This webinar is also being recorded and will be shared with each of you following the event. So as we begin, I'd like to ground our discussion in a few facts. Each year, viral hepatitis claims approximately 1.3 million lives, making it one of the world's leading infectious disease killers. Nearly 287 million people are living with chronic hepatitis B or C, yet millions remain undiagnosed and without access to life-saving care. Despite the availability of effective vaccines for hepatitis B, curative treatment for hepatitis C, and proven diagnostic tools, the world remains off track to eliminate viral hepatitis as a public health threat by 2030. And perhaps the most concerning piece of this is that fewer than 5% of people living with chronic hepatitis B are receiving treatment today, highlighting the significant gap between what is scientifically possible and what is being achieved in practice. These numbers tell us something important. It's about ensuring that the proven interventions reach the people who need them the most through stronger policies, sustainable financing, equitable access to care, and meaningful partnerships. That's why this conversation today is so timely. Although health is not one of the Sustainable Development Goals formally under review at this year's high-level political forum, hepatitis intersects directly with many of the goals that are, including clean water, sanitation, innovation, sustainable cities and communities, and perhaps most importantly, partnerships. Eliminating hepatitis is not only a health priority, it is fundamental to achieving sustainable development, strengthening our healthcare systems, and advancing health equity. At the Center for Global Pediatric Health, we believe that research has its greatest impact when it informs policy, strengthens systems, and improves lives. That belief is reflected in today's program, which brings together leaders in clinical care, research, advocacy, and global health policy to help explore how we translate evidence into action and accelerate the progress towards hepatitis elimination. So thank you for being with us today and for the work that you do each and every day to improve the health of communities around the world. We hope that today's discussion sparks new ideas, strengthens partnerships, and reinforces our shared commitment to closing the care gaps and achieving elimination by 2030. With that, it's my pleasure to begin today's program. Our first speaker is Dr. Claudia Hawkins, Director of the Center for Global Communicable and Emerging Infectious Diseases within the Robert J. Havey, MD Institute for Global Health. Dr. Hawkins is an internationally recognized infectious disease physician whose work focuses on HIV, viral hepatitis, and strengthening global health systems through research, education, and collaboration. We're honored to have her share her expertise and perspective with us today. Please welcome me in joining Dr. Claudia Hawkins.
Good morning, and thank you for that kind introduction. And it's a pleasure to be here this morning to talk about closing the diagnostic gap with hepatitis, the missing link to hepatitis elimination. So I'd like to begin with two cases based on real patients who I've seen in my practice with names and details changed to protect patient confidentiality. The first is Isla, a woman from Chicago with a substance use disorder who was admitted to the hospital with cellulitis, one of many hospitalizations she'd had over the past several years. She had a history of long-standing hepatitis C with multiple positive antibody tests, but she'd never received any viral load testing to confirm whether she was actively infected with the virus or not. When the phlebotomists came to draw blood, they were not successful. Isla's veins were scarred and difficult to access. They tried again later and again, and each attempt took longer and felt more frustrating. By the next day, Isla was agitated and wanted to leave, ultimately then leaving against medical advice before any labs were obtained. Isla didn't have a phone or a home. There was no way to reach her, no results to follow up on, no second chance to confirm infection, and for her that meant no pathway to treatment. What Isla needed to access curative therapy was simple, a diagnosis, but obtaining that diagnosis depended on things she didn't have: good venous access, time to wait for results, medications to help with her substance use, and a way to reconnect with the healthcare system afterwards. Subsequently, she was never diagnosed, never cured, and remains at risk of complications of hepatitis C and at risk of transmitting her infection to others. The second case is Olu, a man in his 30s from Nigeria. Olu first presented to a small clinic near his village after a community screening campaign. A finger stick test showed he had hepatitis B. There was no further testing, no viral load, no fibrosis assessment. These tests weren't done because they were not readily available where he lived. And even if they had been, he wouldn't have been able to afford them. He was referred to a specialist. He wasn't referred to a specialist, and he wasn't told when to return. He left with a diagnosis, but no clear next steps. For the next 2 years, he lived with an infection that he could not feel. There were no symptoms to prompt care and no symptoms in a system in place for him to follow up. When he finally returned, it was because something had changed. He began losing a lot of weight. He could no longer eat. His abdomen was large and distended, and he was in pain. This time, the diagnosis was different: liver cancer, far too advanced for any treatment. The virus that had been detected was years earlier, the cancer had not. These two patients live on very different continents in very different health systems and had different forms of viral hepatitis. Yet their stories share a common theme. They were not failed by lack of effective therapies. They were failed by failures in the diagnostic pathway. And these cases are not unusual. They're typical all over the world. Currently, millions of people worldwide are living with undiagnosed hepatitis, often remaining unaware of their infection until it's too late when they present with complications like Olu did. Even when screening occurs, substantial losses happen across the care cascade, as shown in the slide here, from screening to diagnostic to confirmatory testing, from diagnosis to treatment assessment, and from diagnosis to long-term follow-up. The greatest losses, however, occur at the beginning of the cascade, where people fail to access or complete the testing needed to confirm infection and enter care. Isla's story reflects this challenge. She was lost between an initial suspicion of hepatitis C and her confirmatory diagnosis. The barriers for her were not medical, they were structural: difficult venous access, delayed testing, repeated blood draws, and an inability to reconnect with her after she left the hospital simply because she didn't have a phone. Olu's story illustrates a different failure point. He received a hepatitis B diagnosis, but he never accessed the additional viral load testing and staging that would have determined treatment, as well as monitoring and surveillance that could have prevented his liver cancer. Both cases illustrate the same fundamental problem. Patients are being long lost before they have ever had the opportunity to benefit from the therapies we already have. One of the major reasons for the big gap in the cascade is the complexity of the diagnostic testing pathway for hepatitis. Although hepatitis B and C are different infections, they share a common challenge. Both require a complicated two-step testing strategy. For hepatitis C, an antibody test tells us whether someone has been exposed, but a viral load test is then needed to confirm active infection, as shown in the box on the left here. For hepatitis B, on the right, although the initial hepatitis B screening test identifies chronic infection, hepatitis B viral load testing is required to determine treatment eligibility and guide management, in addition to other tests like fibrosis assessment and staging of disease. This complex diagnostic pathway creates multiple opportunities for patients to be lost along that care cascade, from the initial health visit for screening to the returning visit for confirmatory molecular testing, which may take days or weeks to result, and then having to return again for treatment decisions to be made. The consequences of these missed opportunities are substantial. Patients remain at risk of progression to cirrhosis, liver cancer, and liver failure, while continued undiagnosed infection fuels ongoing transmission and increases healthcare costs. The challenges with testing are further complicated by the high cost of molecular testing, its reliance on centralized laboratories, reagent shortages, fragile chains, supply chains, cold chain requirements, which are most pronounced in resource-limited settings, and in patients like Isla, the challenge of obtaining venous access. So if we're serious about eliminating viral hepatitis, we need to move beyond simply increasing screening and focusing on simplifying diagnosis. Confirmatory testing must become rapid, affordable, decentralized, and available where patients receive care, enabling same-day diagnosis and treatment wherever possible. Given that diagnostics remain the greatest bottleneck in the hepatitis cascade, and therefore to hepatitis elimination, the highest priority should be the development and scale-up of decentralized molecular and other confirmatory testing platforms that make same-day diagnosis possible. This includes expanding the use of dried blood spots, which can be collected in remote settings and transported without cold chain requirements, and fingerstick blood collections, which eliminates the need for venous blood draws and makes testing much easier in community settings and for people with difficult venous access. Simplified diagnostics on their own are not enough and must be paired with simplified models of care that allow people to start treatment as close to possible at the point of diagnosis. This includes streamlined treatment algorithms, task shifting to non-specialist providers, things like telehealth support, community-based testing, peer navigators, and active linking strategies, approaches that have consistently been shown to improve linkage in care and treatment with hepatitis and other infectious diseases across many diverse settings. For Isla, with suspected but unconfirmed hepatitis C infection, a point-of-care fingerstick for hepatitis C viral load with a quick turnaround could have meant a confirmed diagnosis before she left the hospital, and perhaps even the opportunity to start curative therapy that same day. For Olu, access to affordable point-of-care hepatitis B viral load testing and a clear pathway into care could have triggered a treatment assessment, surveillance, and potentially life-saving antiviral therapy that could have prevented his liver cancer from ever developing. Ultimately, the tragedy for Isla and Olu was not a lack of effective treatment. We've already got those tools. But what was missing was a healthcare system and environment capable of reliably diagnosing and confirming infection and moving them from diagnosis to care. So if we're going to eliminate viral hepatitis, this is the gap we must close.
Thank you very much, Dr. Hawkins. We'll move into our next quickfire presentation, and at the end of each speaker's presentation, we will have a moderated panel discussion. So feel free to use the Q&A option at the bottom of your screen to enter your questions, and we will bring those into the conversation as well. So our next speaker, please, it's my pleasure to invite Dr. Gibril Ndow, the Director of Research for the Center of Operational Research on Hepatitis B within the Coalition for Global Hepatitis Elimination. Dr. Ndow is a respected leader in Hep B research and implementation science, dedicated to advancing evidence-based strategies that improve prevention, diagnosis, and treatment worldwide. Please join me in welcoming Dr. Gibril Ndow.
Thank you, Eric, and thanks for organizing this highly important discussion. I just wanted to start by making one proposition that hepatitis elimination is a solvable global health problem. Like you and Claudia have mentioned in your deliberations, we do have almost all the tools we need to achieve elimination, and perhaps viral hepatitis should be positioned as the clearest test as to whether the SDGs can still deliver. And I would start by discussing some of the challenges we currently face. I'm using hepatitis prevention of mother child transmission for hepatitis B in a low-income setting. And I would give the example of Margaret Gay, who's a 23-year-old lady from Senegal, who went to antenatal care for her first pregnancy at 24 at about 4 months of gestation, and like received the routine antenatal care screening test, which include HIV and syphilis test. Her midwives told her that she needed to be tested for hepatitis B as well, but this test was not available within the healthcare systems, and she had to go to a private lab to pay out of pocket for these tests. She managed to do this, came back with her results the following month. By now, she was 5 months pregnant, and she was told that she is hepatitis B positive and needed to do a second test to quantify the level of hepatitis B virus in her blood, which determines whether she needs any interventions during pregnancy or not. Again, this test was not available in the public hospitals, and she had to go back to a private lab. This second test costed about more than $80, which is more than their monthly household income. Somehow they managed to do the test. She had very high viral load levels above 200,000, which is a criteria for her to be on prophylaxis during pregnancy. Now, the drugs that she needed for prophylaxis cost less than $3 per month, but it still is not available outside of the HIV infrastructure. So she was referred to the HIV treatment clinics to get access to these drugs. There were concerns around stigma of taking a medication that is widely known to be an HIV drug when she's not HIV positive. How would she disclose this, discuss with her family and other household individuals? But eventually she got access to the meds, followed all the prescriptions, had good adherence throughout pregnancy, returned every month for her antenatal visits, and gave birth in hospital as she was advised. She was told during antenatal care that her baby, when born, would need to receive a vaccine within the first 24 hours of life to make sure that the child does not get infected with hepatitis B. However, even though she followed all instructions and gave birth in a facility, there was no birth dose vaccine available when she gave birth. And the baby finally got her first hepatitis B vaccine 11 days after birth. Luckily, we followed up the infant, and it was hepatitis B negative, but this story shows all the current gaps that we have. Every missed opportunity in Margaret's case is something that was predictable, that was preventable, and that we can overcome by simple changes in our policy and making sure that access is available for some of these key commodities in hepatitis elimination. And this builds on the case that Claudia had said in terms of access to some of these critical diagnostics and treatment. And it is reflected in the recent WHO report that came out last month or so, that shows that when we compare the burden of hepatitis B and C and the access to diagnostics and treatment, very few of those who are living with these viral infections have been identified, and even fewer of them have access to treatment. So what this has shown us is that over the years, we have made significant progress in advancing the field, in developing the tools that we need: an effective vaccine for hepatitis B, cure for hepatitis C, very low cost daily treatment that can be taken orally for hepatitis B. And the guidelines have started to shift towards that to make sure that things are simplified enough that more people can get access to this treatment that are life-saving and reduces the risk of liver cancer. However, the major limitation now is having access to these diagnostics and having access to these treatments. And because of this, we continue to see a rise in liver cancer cases and a rise in deaths from viral hepatitis. Viral hepatitis is now the leading cause of death amongst all communicable diseases, surpassing tuberculosis and being more than the deaths from HIV and malaria put together. In Africa, we did an exercise to see what is the level of services available at different healthcare levels where hepatitis B care can be provided. At the community level, which are the community health posts, which are closest to the individuals. That's where you take your child when they get a temperature, or if someone in the family has a diarrhea, all the way to the tertiary clinics. And these are usually like the reference clinics associated with medical school teaching hospitals and are usually in the larger capital cities. And we found that of the most critical commodities needed for hepatitis B and C care, most of the services that we need remain concentrated in this specialist setting, and most of them, even things that we consider to be very basic, are not available at the primary care levels where most individuals would go to seek help. And this is a major limitation to both how we can decentralize access to hepatitis B care, but also it involves patients having to travel significant distance or incurring significant out-of-pocket costs just to be able to access services that should normally be available. In trying to overcome these, we've tried to be innovative in piloting different models of care that can hopefully be scaled up to identify what would be the barriers and the facilitators of these. Within preventing mother-child transmission, we've looked at different models that can simplify care, leveraging on the existing antenatal care platforms and within the triple elimination agenda to add hepatitis B screening, training of healthcare workers, getting access to the diagnostics within the antenatal services that can provide assessment and prophylaxis for women on the same day that they have been tested for these infections, as we have been able to do for HIV and to some extent for syphilis. And most importantly, just raising awareness amongst healthcare workers and mothers-to-be to empower them to make sure that the demand is created, that advocacy is pushed forward. And we hope that ultimately we can have hepatitis B prevention within the same existing antenatal care platforms as we have managed to do for syphilis and HIV infection. But to go even beyond that, to simplify these, so that the care that's provided aligns with the realities on the ground in terms of what services are available for now. And in terms of doing this, the WHO has simplified the hepatitis B PMTCT algorithm to state that if you're in a context where you do not have access to the additional tests that are needed to identify someone who needs prophylaxis, you can start them on these low-cost drugs just based on a positive hepatitis B surface antigen test. So the guideline is there, but again, access to the drugs are not there, but also understanding what changes would be needed within our healthcare systems to be able to operationalize these guidelines are also limited. And in line with this, we're starting demonstration projects in Uganda, Malawi, and the Gambia to see how we can bring this simplified guidelines of test and prophylax all within antenatal services in Africa to become a reality. And I would remind us that Africa represents the highest burden of new hepatitis B infections globally, with 2 out of 3 new infections in the world happening in Africa. And we can bring a stop to this, close the tap of these new infections by doing simple things that can be integrated within our HIV, within our antenatal care platforms. And as a last mile as well, the hepatitis B vaccine that needs to be given within the first 24 hours of life have not been taken up evenly. Few countries in Africa have adopted this birth dose, and as a result of that, about 1 in 5 children currently in Africa receive the birth dose, with 4 in 5 not receiving it, either because it's not available in their countries or the policy has been adopted, but fragments within the delivery system prevent the vaccine to be available within the first 24 hours of life. There are multiple strategies that have been explored to be able to overcome these. One of them can be to leverage on innovations that have started to come up within the vaccination space. The most impactful, in my opinion, of these being the microarray patch, which the vaccines innovations prioritization strategy, which is a framework of Gavi, Global Fund, WHO, Gates, and other international stakeholders, have identified this as the highest priority innovation for overcoming immunization barriers. At the moment, there is no MAP vaccines being developed for hepatitis B, but it's being developed for other diseases. So again, driving the advocacy, making sure that resources are thrown at this to ensure that they can be used for hepatitis B birth dose vaccination would be a strong point. And this would be a game changer for both deliveries in facilities like Margaret's child, who did not get access to the vaccine because it was out of hours, the EPI program were not there, supply cold chain is not always available, but also for out of facility deliveries, which we continue to see in some of the countries which have the highest rates of hepatitis B, especially in Africa, for example, in Ethiopia and Nigeria. And then looking beyond just caring for the mother as a route for transmission and infecting their unborn child, but themselves as an individual who needs care and needs to be protected. And we are looking at different modalities where we can simplify hepatitis B care so that it is decentralized, even down to the areas where there is no access to standard laboratory services. And by this, we are looking at models of care that only use point of care diagnostics, some that are available currently, others that we can develop. And hopefully all of these together would solve the problem. And in terms of what we can do today, using the tools we have, understanding the barriers to access, and using the guidelines that are available, we have come together as a community to work with Africa CDC, which is a policy and body within Africa, to develop a toolkit that is a how-to guide for healthcare providers at every level of care, and from the primary and community facilities all the way to the tertiary levels, to demonstrate how they can still look after individuals with hepatitis B and C at their level using the tools that they have. And these are things that we can operationalize today with the access, with the resources and the health workers that we have, and we can leverage on other global opportunities like the Global Fund, which indirectly supports viral hepatitis care and provision, with Gavi supporting birth dose vaccination and scaling up some of the implementation programs that are happening now to leverage existing resources, engage our policymakers to improve the policies, but not stop there, but go further to assign budget lines to operationalize these and make them feasible, integrating services so that we can have decentralized high-level quality of care, and overall simplifying care to all of these, and making access to tenofovir and other commodities to be easy and affordable. The drugs are available at very low cost levels. The diagnostics are available, some of them at low cost level, but making sure that they reach the communities that need them mostly. And finally, to make sure that timely birth dose vaccination is available. I think if we had an effective vaccine for any other disease like HIV or malaria, we would move mountains to make it available. We have one for hepatitis B. We need to do whatever we can to make sure that it's available where it's needed most. Thank you very much.
Thank you, Dr. Ndow. That was incredible. If you see me glancing away, it's because I'm taking notes on my phone. Have a lot of things to come back to, and I'm learning a lot this morning. But thank you for that. We are now going to move to our next presenter, Dr. Sue Wang, who is the Medical Director of Viral Hepatitis Programs, as well as the Center for Asian Health at Cooperman Barnabas Medical Center. She's also the former president of the World Hepatitis Alliance. Dr. Wang has been a tireless advocate for expanding access to hepatitis prevention, screening, and treatment, with a particular focus on addressing health disparities and improving care for our underserved communities. So please join me in welcoming Dr. Sue Wang.
Thank you, Ulrich. I'm very honored to be here. Thank you for the organizers for having me for this really important session. So today I'll be talking about hepatitis elimination and the critical need for a simplified and person-centered approach. So I'm going to start off with this story as well. And it kind of exemplifies the cost of complexity. So Chinwei is a mother with hepatitis B in a rural sub-Saharan clinic. She's seeing her local general practitioner. She's worried about having Hep B, and she asks what it is she can do about it. She wants to be proactive. She's also thinking about having another child. So this ties perfectly with Gibril's story. The GP tells her that she needs to go to the capital several hours away in order to see a liver specialist for her hepatitis B infection. Yet tenofovir TDF is sitting on the pharmacy shelf, available and at a cost of $2.50 a month, but she is not offered treatment. What are some of the barriers? Well, most guidelines have been designed for specialists requiring many tests, including Hep B DNA and fibrosis assessment. And as Gibril pointed out, even getting ALT is a problem in many settings. And all of these are very difficult for her to access at her rural post. So this is why we are talking about simplified service delivery and decentralization. This is actually a focus of the WHO Consolidated Hep B and Hep C guidance, which was published just earlier this year. It's in Chapter 6. It's a great kind of guide for countries as we talk about how it is we get care to the communities who need it most. So this lays out a framework for simplified service delivery based on 4 pillars. First, we have decentralized delivery, where we're really trying to move testing and treatment out of the tertiary centers into primary care clinics and community sites. Second, we want differentiated care, where we are able to handle simple cases locally and refer complex ones, or think about differentiation based on resources. Third, we want integration where we can embed hepatitis pathways into existing systems such as antenatal care, primary care, HIV clinics, and harm reduction services. And fourth, task sharing. It's really important for us to equip our frontline workers, our GPs, our nurses, and other frontline providers to deliver care, even parts of care, and also figure out where they can collaborate with specialists. So another really important dimension is making sure we have person-centered care. Simplification isn't all just about systems, it's about people. And so I want to showcase this declaration from people living with hepatitis B, which was published in the Journal for Viral Hepatitis by me and Danjuman Atta. We were both presidents of the World Hepatitis Alliance and both living with hepatitis B. And in this declaration, we say that we, representing people living with hepatitis B, want whole person care, not just care focused on our liver. We want doctors to consider the overall impact of hepatitis B on our entire lives, including our careers and our social well-being. And so as part of that, patients really want clinical flexibility. We want simplified, adaptable strategies that prioritize our values over complex laboratory parameters. This also includes recognizing that there is stigma and discrimination with hepatitis B and C, and we must address social barriers and challenges as we talk about delivering care. And there is a gap from what patients want and what patients are getting. So the Hepatitis B Foundation did a survey, and this is in preparation for the WHO guidelines that came out in 2024, and revealed a disconnect between what patients want and actual care delivery. So in this, patients actually wanted more active participation in their care. The vast majority, 85%, felt like they wanted more than what they were getting. And in terms of who was actually getting clinical follow-ups, only 49% reported seeing somebody for their hepatitis B every 6 to 12 months. And when they were being seen, 42% reported not being told that treatment options exist. So not that they were even given it, but that they were even told that there was something that could help treat their hepatitis B. So one of the issues that we're facing is that many people fall through the cracks when they move through our care cascade. This was a meta-analysis by Dr. Stockdale and colleagues in The Lancet, which revealed that there's a global attrition of about 12 to 27% of people at each phase of the care cascade, even in well-resourced settings. So we need to really empower our primary care and treat. Currently, the way it works with our current guidelines and what's expected in our model of care is that treatment eligibility assessments happen much fewer, much less likely than if you are in primary care than if you are in a specialist setting. So only people in about 50% of the time in primary care settings get treatment assessed versus 73% in specialist settings. And in terms of initiating therapy, only 49% of people, and this is for hepatitis B, actually start therapy versus 78% in specialist care. So we can tell that we really need to do more training and equipping of people of the primary care workforce in order for them to do eligibility assessment and antiviral treatment initiation. And we find that people who are started on treatment are more likely to stay in treatment. In a study, it showed that 52% of people were lost to care if they were not on antiviral treatment. And so just shows that we need simplified pathways and expanding decentralized testing and treatment. So this brings me to an exciting initiative happening right now, the STITCH project, which is stands for Strengthening the Integrated Treatment and Care for Hepatitis. This is one of the many projects out there, and Gibril's team, COR-HEPB, is doing a number of these projects also happening around the world. So we have a lot to learn from these kind of projects. So the STITCH program is happening in Vietnam and the Philippines, and they're focused on co-designing a program with the community to test and scale a decentralized, integrated, and a people-centered model for Hep B and Hep C in primary care. And what makes it unique is it's a collaborative approach. So bringing together national and subnational health departments, people living with hepatitis through organizations like Yellow Warrior Society and the Vietnam Women's Labor Union, along with academic partners at Harvard and the University of Philippines, with private support from industry. And you can see the timeline here, basically, where we're now actually at the scale-up part, and they're looking at sustaining, evaluating, disseminating. So there's a lot of lessons to be learned here, which I'll go over. So their focus is really to develop people-centered care in primary health care, and there are 5 key elements. First is that a person living with Hep B is given the correct diagnosis, treatment, and counseling. Second, that they are tested in a timely way and linked to care to prevent worsening of illness and interrupt transmission. Third, that care is accessed at the most convenient facility and appropriate level of the health system for them, and it is financially inclusive. Fourth, the right team, that care is delivered by primary care providers and teams that are trained, supported, and available. And fifth, that people living with hepatitis feel comfortable, supported, and clear on the next steps across their journey. So they have some preliminary data that is interesting to look at. So by doing this kind of systems change, they have actually seen a decreased time to linkage to care. So this graph kind of shows the average number of days from screening to the linkage to care. So you can see early, when the program first started in 2024, it took 62 days in Vietnam and 84 days in the Philippines and 130 days for Hep C in Vietnam to get somebody linked to care. By early 2025, those numbers dropped to just 5, 25, and 29 days, respectively. And by early 2026, we're seeing linkage times of just 2 to 6 days across all the sites. So systems change, simplified pathways, and decentralized services drove this dramatic improvement. And here are the results of the care cascade looking at Vietnam, and they were able to get 80% of people linked to care, and the majority of those deemed eligible for treatment did actually initiate treatment. There is more of a loss in Hep C, and that was thought to be due to the cost of the Hep C medications, although they have come down dramatically. So let's talk about cost and how this program, interestingly, is actually revenue generating and financially sustainable. So when they did a microcosting analysis in Vietnam, they found that the primary care model costs 70% less than tertiary care and represents only 4% of the average annual income. So per person, the annual costs in a tertiary care center ran about $610, and the intermediate model is $480, and the STITCH model cost only $143. And the facilities also were able to generate an average of $61,000 USD per year with thadditional revenue from increased utilization of the services. So it shows that the simplified model does reduce costs across through therapies, staffing, and the labs, but it is able to be sustainable for the sites because it generates revenue as well. So we've heard this time and time again that we have many policies, lots of guidelines, lots of guidances, lots of pilot projects. And yet, even if there's funding and there's commodities, people often just don't know where to start. And the STITCH team has developed a modular subnational facility toolkit from 3 years of their implementation, similar to what Gibril's team has done. And I, encourage everybody to use these resources that have come out from these projects. And this one, you can scan for the toolkit. There's over 200 pages and 30 different tools that includes templates like job descriptions, counseling scripts, and also an AI-enabled chat platform. So I encourage people to explore these resources so that they can be implemented and adapted to other settings. So finally, just want to leave everybody with this. By simplifying and decentralizing services directly to communities, and addressing the psychosocial realities of patients, we can transform global viral hepatitis elimination from an ambitious policy target into an actually achievable real-world reality. Thank you.
Thank you very much. Moving on to our next presenter here, it is my pleasure to welcome Dr. Nida Ali, Director of Government Affairs and Partnerships for the Coalition of Hepatitis Elimination, Global Hepatitis Elimination. Dr. Ali works at the intersection of policy, advocacy, and global partnerships, helping to build collaborations that accelerate progress towards elimination. Her leadership in engaging stakeholders and advancing public health initiatives has been instrumental in driving meaningful change. So please join me in welcoming Dr. Nida Ali.
Thank you. It's an absolute pleasure to be here with all of you today. Since my topic is raising hepatitis on the UN agenda, I want to start with the story of a country that once had the highest hepatitis C infection rate in 2015. And today, the same country, Egypt, is the global gold standard for elimination. So this is Egypt's story, and the real lesson in the story is not about medicine. It's about what happens when political leadership decides that disease is no longer acceptable. Now, how did this crisis begin? Sort of unable to advance my slides. Yeah. So it actually happened decades ago due to mass campaign against schistosomiasis between 1950s and 80s. So when inadequately sterilized needles were used and then reused and ended up spreading hepatitis to millions. So it's a reminder that today's health interventions can quietly become health challenges of tomorrow if we don't get the basics right. And in this case, it was injection safety. So the Egyptian government launched this campaign with the name that is as bold as its ambition, the 100 million healthy lives. The objective was to screen the entire population and treat every single person that is found to be carrying the virus. And when I say the entire population, I mean this went far beyond the walls of the clinics. Testing was not just inside the hospitals. It went to markets, it went to clubs, mosques, churches, even barbershops, and in some cases, to the household. So between 2014 and 2020, Egypt screened between 50 to 60 million people. And that is almost like testing the entire population of Italy for one disease. And it didn't stop at testing. By the end of 2020, 5.5 million people had been cured, with 92% of everyone who was diagnosed as positive for carrying the virus actually getting the treatment. Now, Egypt didn't wait for the world to lower the prices of the cure. It built its own. So it started with the manufacturing infrastructure and setting the price within the country by the country. So this is the classic example of what domestic ownership looks like. So first was market shaping. Egypt authorized local manufacturing of generic cures and negotiated hard, driving the price of the full curative treatment down from $900 to under $40. So second, there was a lot of political commitment and strong domestic financing that made testing and treatment completely free for the local public. So the price drop and reduction in out-of-pocket cost from generic competition and policy, it engaged both these components because generic manufacturing needed the government's authorization and procurement muscle behind it. So the price didn't fall until Egypt negotiated it down and manufactured locally. So let's look at the progress. Egypt treatment scale-up has been the single biggest factor for 28% decline in new hepatitis C infections in the Eastern Mediterranean region. Egypt's own new hepatitis C infection rate fell by 97% nationally between 2014 and 2022. So for numbers, this translates from 300 cases per 100,000 down to 9 cases per 100,000 today. And this is not just the example of good public health, it is good economics as well. I know Wang talked about the economic benefits. So in case of Egypt, the program is projected to become fully cost-saving by 2029. And between 2018 and 2030, it's expected to save $35 million in direct healthcare cost and generate an estimated $4.7 billion in broader economic gains. And of course, the world took notice of that. In October 2023, Egypt became the first country in the world to officially be validated by WHO as having a gold tier status on the path to elimination. This means that Egypt had met the coverage targets needed to eliminate hepatitis C incidence and mortality before 2030, the first in the world. And Egypt didn't stop at its own borders. They took the route of international diplomacy and international cooperation and provided treatment to countries across sub-Saharan Africa. Imagine a country that once had highest numbers of Hep C cases in the world, and they are now exporting cures. I know most of us are familiar with the global numbers, but I have to stress this picture here. Hepatitis B and C cause more deaths than HIV and malaria combined. Two big infectious diseases that received a lot of international attention and assistance, which is why the mortality numbers are what we see here today. So why hepatitis doesn't receive that much attention and resources? We know that Hep B and C account for nearly 8 times as more prevalent infections than HIV, yet it receives less than 1/10 of global funding. So WHO estimates that to achieve the elimination targets, the investment is needed to be scaled up by $8 billion a year by 2028. So the lesson is simple. Hepatitis elimination is not a technical challenge. We already have the tools. We know we have vaccine for hepatitis B, we have treatment for Hep B, we have cure for hepatitis C, and yet globally, the mortality is still rising. We also have the proof of concept in the form of Egypt's example, and there are many other countries' examples as well. So if the tools are there, why isn't the money following? That's a big question. It's a big funding gap that nobody is watching, and what's missing is enough organized political attention and commitment. So which is precisely the gap that Group of Friends exists to close. So 4 years ago, a small group of us decided to build this attention. And before 2022, there was no dedicated political home for hepatitis at the UN. Advocacy was fragmented across sectors, and hepatitis was largely absent from the UN discussions and high-level political agendas. But no disease has ever reached elimination level through technical guidance alone. We have examples from the past. We were able to make progress for smallpox, for polio, for HIV and malaria because there was the highest level political commitment. So building such an infrastructure for hepatitis, it is, we feel the need because the mortality numbers, like you saw, 1.3 million people dying every single year, that is comparable to TB. And of course, way off as compared to HIV and malaria. So the Group of Friends to Eliminate Hepatitis is an informal coalition of member states at the UN, and they have one mission: to elevate hepatitis on the global political agenda. So it started with one country's invitation. This is the letter that was sent out by the permanent representative of Egypt to the UN, Ambassador Osama Abdul Khalik, and he invited all the UN missions to join the cause. And this wasn't just a big guest list, it translated into real influence. As you can see in these pictures here, the picture on the left is from 2022. There were 12 member states at that point, and at 2025 annual meeting of the Group of Friends, we had 63 member states overall that have participated in Group of Friends over the years. So from 12 countries to 63 now, we successfully managed to send the message across. So hepatitis is now part of the broader UN discussions. Liver cancer prevention through Hep B and C elimination has been folded into NCD advocacy. It was part of the political declaration on non-communicable diseases. We have engaged 63 member states, We secured a ministerial statement, and we laid the foundation for future high-level meeting at the UN, bringing this advocacy, technical aspects from Geneva and political aspects from New York. But let's be honest about what the underlying epidemiology and the latest numbers tell us. So WHO released their global report on hepatitis in 2026 this year, and it shows that despite some progress, we are still off track on elimination. So This 2026 scorecard is a humbling reminder that we are still way off on achieving the target of elimination. Hepatitis B related mortality has increased by 17% since 2015, and diagnosis and treatment gaps still remain severe. Most people living with either Hep B or Hep C still don't know their status, and birth dose vaccination has stalled at 45% globally, and just 17% in the African region, which carries the highest burden of new infections. So the gaps are wide, and I think they deserve urgent attention, urgent global attention. So what do we need beyond 2030? Evidence alone does not move member states. We have all these scientific advancements that we can have, but politics, priorities, and pressure is also very important to garner that kind of attention that it deserves. And we also learned that trust takes time, and informal diplomacy is often something that matters more than formal processes. So policy windows are created and not waited for. Egypt is a shining example that the proof of concept is there, the science work. The group of friends is showing us that politics can work too. So if your mission hasn't joined yet, I'd love to talk after this session, because hepatitis elimination was never a technical challenge, it's a political one. And that means everyone here today is already a part of the solution. So thank you.
Thank you very much for that. That is a powerful way to close out the quickfire presentation portion of our time together. And I'm thinking what amazing work it is with the group of friends as an example of a science and policy interface where we are getting the right people in the right room at the right time. And I think that partnership and collaboration is such a key element of moving this discussion forward. So in that vein, or in that mind, we are going to move now into our moderated panel section. Pleased to introduce today our moderator, Dr. Ravi Javari, the Division Head of Pediatric Infectious Diseases at the Ann and Robert H. Lurie Children's Hospital of Chicago. Ravi is a nationally recognized expert in pediatric infectious diseases and viral hepatitis, and is a respected clinician, researcher, and educator whose leadership has helped shape the field through research, guideline development, and medical education. We are delighted to have him guide today's discussion. So please join me in welcoming Dr. Ravi Javari.
Thanks, Eric. Appreciate your efforts to organize the session, as well as our team at the Center for Global Pediatric Health. And just a terrific set of presentations by our esteemed speakers. And so it's a delight for me to be here. So I have a couple of prepared questions, and I'll mix in. I see that there were a few questions that were entered in the Q&A, and so I'll try to weave them because there's a lot of overlap. So one of the topics I wanted to just cover is this idea of diagnostic testing and point of care testing. And we have available point of care tests for many common infections like group A strep, flu, RSV, and the like. But what's made testing for hepatitis B and C such a challenge that we haven't yet been able to do it? Is this a technological issue, or do we think this is a policy issue, or both? And I want to weave in a question from one of our attendees just about accessible viral hepatitis C viral antigen testing. That there are obviously a lot of high associated costs, and we need a better test to allow for decentralization and less resource settings. So who would like to take that question? Claudia, maybe do you want to start, because you touched on it at the beginning?
Start. Thanks for the question, and some really important points being brought up there by the audience questioner as well. So I think it's actually a combination of both the technology and policy, but I do think technology is the biggest barrier. Point of care tests are the easiest to develop when they're sort of detecting, when you simply detect the pathogen, and that's enough to make a treatment decision. And as you saw in my presentation, that's not the case with viral hepatitis, but is the case for things like flu and group A strep. And the nice thing about sort of flu and group A strep is that they have very high pathogen levels. They're kind of easy to detect in respiratory samples. The kind of devices, the tests are easy to make. And then you get the test back, it confirms the diagnosis, and then you can start treatment immediately. And so, we don't have that luxury with hepatitis B and C, as you saw in my presentation. And then the other thing is the sort of the cuteness of these viruses, and like flu and influenza is a good example. And other respiratory infections, is that there's just this, their acute sort of illness and their acute presentation, it obviously creates this enormous demand in healthcare settings. And so, obviously that sort of drives a bit of attention, right? And the commercial investment and innovation. And we're just not seeing that with hepatitis. And because of the sort of complex approach, we need that molecular testing for confirmation, at least with hepatitis C. With Hep B, we can sort of get around it, I think, for make treatment decisions. And we just and making that simple sort of point of care test is actually very challenging. You to need something to detect very low viral loads with a lab quality accuracy, and then have to do all those sort of steps like nucleic acid amplification with a low cost platform is really challenging. So with that said, I'll answer the second question. I agree with Cepheid. It's not the answer, right? It's not really a point of care. It's a near test, and it's does have its challenges. It has been used very successfully in countries where they've integrated it into their testing, and we've seen examples countries which we should maybe talk about later where that's been used successfully. But in real life, in real practice, especially where I work in Nigeria, it's just not available, and the reagent costs are high. It's difficulty accessing it. We don't have if you have high cost of reagents, high cost of the test, you're not driving that demand for testing, and you don't have the the number of samples to sort of drive the testing. So it isn't the answer. We need a better point of care device. We are working, myself actually, and a colleague of mine are working on one, but there are many that are in development, and hopefully we will get to the point where we have something that is, easily accessible, but also right at the point of care, right to make that treatment decision straight away, and then at a very low cost that sort of drives that demand and gets people interested. I'll stop there and take
Thanks, Claudia. Any of the other speakers want to make a comment about point of care testing? Gibril?
I completely agree with Claudia. I'll just add that I think the policy and demand parts are almost as important barriers as the technology here. Throughout, we've always tried to fit technology that have been developed for other diseases to serve hepatitis B and C. That needs to change. We need to see this as an important communicable disease, as a major global health problem that would require the same focus, the same attention, the same support and financing that specifically looks to address its problems, rather than trying to fit it within the box of what we are doing across other platforms. And perhaps one of the things we can do is just to increase demand for this. That would help with the cost of commodities and the testing, but it can also show to investors and developers that there is a potential market here that is worth investing in. So I think bringing up the policy angle, the financing and the demand to the same level as we do for other diseases can also help with the access to diagnostics.
Yeah, thanks so much.
Robbie, I think sorry, I was going to say also, it's interesting. We have the technology, but it's not available everywhere, right? It's very spotty. So the point of care surface antigen test for Hep B has been around for years, but it's not available in the US, right? Even though the company that makes it is headquartered in the US. So it's demand, like Gibril was talking about, but also licensure, right? It has to get through FDA license. The company has to be convinced there's demand. And FDA did downgrade the categorization of Hep B and Hep C testing. So it's not as onerous now. It's not category 3 anymore. But we're still also waiting for the companies to come forward to get a license. So it's so many things. But yes, having these point of care tests is really critical.
All right. In the interest of time, let's move to another question. One of the questions that was submitted relates to the topic of generic drug access. And so, Nida, maybe I'll push this one to you first. So the Egyptian story obviously is terrific in so many ways, but clearly one of the key factors was access to very cheap, generic, locally manufactured DAAs. And, the audience, I'm sure will remember, we really only made significant progress against HIV when we had widespread, locally manufactured generic antiretrovirals. And so what's stopping us from breaking these barriers down and emulating the model that Egypt has to sort of export more locally manufactured drug to neighboring countries and other parts of the world?
Yeah, I think I'll take that question. So, of course, access to affordable generic antivirals has been one of the game changers for hepatitis C elimination in Egypt because generic antivirals have transformed what is possible in terms of the cost of treatment. And in fact, many countries, apart from Egypt, have lowered the cost of treatment, and it's no longer a primary barrier. So the barrier that comes before DAs is, of course, extremely high cost of confirmatory diagnostics, the PCR, and for that matter, gene expert, any test that confirms the viral load. So the larger challenge is that millions of people are still underdiagnosed, and the national programs are still underfunded by domestic governments, and hepatitis has not received the same level of political attention as HIV did. So in some middle income countries, access barriers still persist, even for the DAAs, for example, the licensing or pricing constraints. And I think we should continue to work to expand equitable access and advocate for that. But ultimately, affordable medicines alone, they do not eliminate hepatitis. It has to be complemented by political commitment, sustained financing, stronger screening programs, and integrated health systems. That's my view, yeah.
Thanks. Comments from any of the other speakers?
I can jump in here and also say that think pathways to accessing these drugs and how they're negotiated has remained a major barrier, especially in LMICs. In our talks, all of us, we've referenced that tenofovir is available at $2.50 per month, and this is the negotiated global procurement price. But for most patients in Africa, for most clinics, for most countries, they're accessing these drugs at up to $50 to $100 per month, which is way outside the budget of the average individual living with hepatitis B, for example. So finding mechanisms to overcome some of the challenges around countries or programs having to negotiate individually rather than like pooled negotiating prices, and just having easier pathways to have these drugs licensed and registered so that each individual side, each country doesn't have to do this at their own level, would help overcome and unlock access to these drugs that we currently face and that lock out most patients who need these things.
Yeah, thanks. Any other comments on that topic?
I think I would just add into just like we're doing here, the importance of civil society and participating at every level, right? Whether it's the United Nations or your local Ministry of Health, having the public voice pushing these stories, getting this information out, helping people understand the pain points. It's incredibly important. And I think that hopefully, convenings like this and civil society pressure at the UN level is going to help move some of this forward. But, don't forget to do that in your community and make sure that the people who are living with these challenges are at the table talking about what they need, not just living with the assumptions that somebody else has made for them.
Yeah. Thanks, Art.
Yeah, that's such a great reminder, I think, to partner with your community wherever you are, because like Nida had said earlier, it's not like we don't have the data, it's not like we don't have the tools, but it's often the stories that are so compelling, right? Hearing individually how it's impacted people's lives, their families, that really helps move things. And we've seen that obviously with HIV, but cancer and this is what we need for our hepatitis to raise the prioritization.
Thanks, Sue. So I want to pivot slightly from that just to talk about perhaps the experience in other countries. So one of the questions was really about the success of the Egyptian initiative for 100 million healthy lives, relied on mass screening and high treatment linkage, and what other implementation strategies have been scientifically proven to sustain high linkage to care rates, and then how can they be adapted? So can we talk about perhaps the examples of other countries for hepatitis C and hepatitis B elimination? You touched on some of them in your presentations, but there are others that you want to specifically highlight. And Sue, maybe I'll start with you, and then we can move maybe to Claudia and through the other speakers.
Yeah, I think linkage to care is like that pivotal thing that is so difficult, sometimes getting people from testing to an actual place where they can get care. And I'm not, sure that any place has done it perfectly. I think there are so many examples and pilot tests, and a lot of it depends on your healthcare system, right? Whether you have universal healthcare, whether you're in an urban area, not urban area, and access and what you have. So I think it does have to be really specialized or like has to be matched up to what the resources and the settings are. I think we've seen a lot of places do really well if everything's like in-house. You've got a system where the testing is happening and you can get somebody to primary care or a specialist, within the network. People who have EMRs or, I think a lot of our what technology can be used, and it doesn't have to be something super fancy. Even just telehealth is important. We've seen that really happen well with Echo in terms of telehealth consultations. But even people can see direct, not just providers helping other providers, but even patients can access physicians through telehealth, and WHO has a whole guide on that too. So I think it does require really innovating strategies. But as we've talked about here, really getting it down to the front line in primary care, I think is a critical thing, throughout the world for Hep
Yeah,
B and Hep C. Yeah.
thanks, Sue. Claudia, do you want to talk about some of the other examples that are out there?
Yeah, I mean there have been several success stories, and I think I agree with Sue that you have to have sort of a lot of things in place, and you have to have sort of a lot of you can't just be one strategy, right? Multiple strategies that sort of go from decentralizing care, integrating care, and right through to sort of these novel patient tracking, getting people into care, engaging the communities, etc. I mean the places that come to mind, of course, that we all talk about is Georgia. Rwanda, and Nigeria, at least one of the states in Nigeria where they've done an amazing job in really trying to eliminate their hepatitis, or at least strive to eliminate hepatitis. I know Georgia, early in the days partnered with Gilead to, have free of charge DAAs for hepatitis C. They have a very large national hepatitis C testing programs being ongoing forever. The nice thing that they did, or what they were able to do, is integrate point of care testing with a gene expert, and that was an example I was sort of giving earlier where it did work. And they also use core antigen, which has its up and down sides, but they were just able to get quick testing, and then they had that linkage part already sort of in place so that they could get these people quickly tested but into care thereafter. And really, they got sort of two-thirds of their they managed to reduce their chronic hep C prevalence by two-thirds after all these. And then Rwanda's just a great African example of where they were able to also, for Hep C, negotiate direct acting DAA prices, and then have really targeted testing campaigns at high risk populations. They had these great sort of, really great oversight at the local level from a governance level, and also these sort of targets that they met at each within states. As well as some really good hepatitis B campaigning, which has really they've done a marvelous job of also screening. For Rwanda, over 7 million people have been screened for Hep C, and the Hep B vaccination rates and testing has also been pretty remarkable in the millions. So they're on track to meet the WHO 2030 targets well before 2030.
Yeah, thanks. Thank you for highlighting those.
Got to
Any other?
mention also,
Yeah.
Robbie, the peer navigators. That's something that has come up and has been really successful. I think with Hep C, we've seen that happen during the interferon days, but also for Hep B, we're seeing a lot of kind of community health workers and peer workers in the UK and Australia. We've seen like a real movement of people living with Hep B helping other people navigate care in their own language, with the culture. All that is so important so that people trust the healthcare system. So another place where partnership with the community helps with outcomes too.
All right, thanks. So I wanted to talk a little bit about stigma, reflecting on the example in Egypt, as Dr. Ali mentioned, the Hep C epidemic really was driven by a public health decision gone awry. But In so many other parts of the world, including here in the US where we're based, Hep C and many current cases of Hep B are really driven by injection drug use. And so I want to ask, how does that stigma and the moral judgment impact our willingness to respond? And if it does, how do we work to get past that? And so I'll open that to anyone.
Yeah, I think I can start.
Please.
I'll make one distinction. Injection drug use is most certainly is one of the drivers of transmission in many settings, particularly for hepatitis C, but it's not the dominant route everywhere.
Correct.
Hepatitis
Yeah.
B remains highly prevalent because of mother-to-child transmission and unsafe medical practices and horizontal transmission in early childhood in many low and middle-income countries, but the epidemiology differs across all the regions. That said, I think the stigma is one of the biggest barriers to elimination because disease becomes difficult to prioritize politically when it becomes associated with one group, high-risk group, or marginalized population, or a moral judgment element rather than being viewed as a public health challenge. So one of the reasons Egypt experience is so powerful is that hepatitis C was reframed as a national development challenge rather than a problem of the individual behavior. So the response was focused on universal screening, broad access to treatment without asking a patient their status and their individual behaviors. And this was largely driven by political leadership and not assigning blame to the patient. At the UN level, this is also why framing matters. If hepatitis is discussed only as an issue affecting certain population, political support will always be fragmented because the issues that lower middle income countries have, we simply don't see that kind of momentum or that kind of attention in the higher income countries that have completely different priorities. So I think the framing matters, and if we frame it right, it becomes much easier to mobilize the sustained political attention.
Yes, thank you. I couldn't agree more.
Yeah, I think
Other comments from speakers? Yeah, go ahead, Sue.
we have to reframe it a little bit, right? I think it's been really easy for it to be both Hep B and Hep C pegged as related to behavior. But we have to frame it as cancer issue, right? It's liver cancer prevention. We have to frame it as maternal child health. We have to frame it as health equity. And so there are many ways of looking at this. And I think that in concert with normalization through storytelling. So people living with Hep B and Hep C coming out, telling their stories. So people recognize these are your neighbors, these are the people you work with, these are your family members. And so we've seen that really, that swell up of, patients being willing to share their stories happening. So we're at a really good time now, I feel like, where you can find all these stories out there. And so it's a good time for us to capitalize on all this happening.
Yeah, thanks. Claudia, you were going to say something?
Yeah, I mean, I'll just add, I think there's some education providers that is needed as well. I mean, I think I still sometimes see this in my practice that, we are often judging people on how they got an infection and really we shouldn't be, we need to move beyond that, right? And really instead focus on what the infection really is, how we're going to prevent transmission, how we diagnose it and make sure that they're getting adequate care. So, and I think providers need to play a role in this as well. So,
yeah,
thanks for
I'll
that.
just add that education, I think it's one of the most important, perhaps, for to overcome the issues we have around stigma, and it should go beyond just the providers, to the community as well. If we went into most communities, even like where literacy levels are relatively low, and you ask, there is that basic understanding of the linkage between, for example, smoking and potentially lung cancer, between HIV untreated and AIDS, like between mosquitoes and malaria. But that link between viral hepatitis and liver cancer is not there. And in most communities, like the outcomes of viral hepatitis, which are liver cirrhosis, liver cancer, and the sequelae and the complications are seen often as maybe effects of witchcraft or karma because you did something bad previously, and that's why this is happening to you, and not linked to a preventable infection. So raising awareness would help, like communities to be kind of like more receptive, but for them to also, like those who are affected, to stay in care, to seek the care that they need, and to support others who have this. And ultimately to see prevention and screening as tools for cancer prevention and not just to identify individuals who need more services.
Yeah, no, thanks. Thank you. let's see, where do we want to go next? So I want to, because I'm a pediatric ID person and I've spent most of my career talking about infants, children, pregnant women, I'm going to take a moment just to talk about this group. So when we think about elimination, really we're talking about everyone being included. And historically, research and even policy have actively excluded children in pregnancy from treatment and research. How do we change our thinking to make the default option inclusion rather than exclusion?
Well, I can start with the patient's story.
Yes,
I
please.
was doing the research project in Pakistan, and we came across a family. The mother had Hep B, and she had 4 children. 3 out of 4 of those had positive hepatitis B plus viral load. So the only child who didn't have hepatitis was the only one who received hepatitis B birth dose. And the child that she had after that, she asked the nurse if this child needs Hep B birth dose because the previous one was vaccinated at birth. The nurse actually said no, he doesn't need any. So the youngest child also ended up acquiring Hep B. So this was classic example of acquiring hepatitis in a healthcare setting. And then when we approached this household and got the children tested, we measured their viral load, we measured their Hep B E antigen antibodies and their liver tests. And if only guidelines existed to treat under 12-year-olds,
Mhm.
that's what the mother kept asking us. And the oldest one was 10 years and the youngest one was 3 months old, and there were no guidelines to initiate treatment for any of them. So that's absolutely unfortunate that pediatric population is excluded from that.
Yeah.
I don't have the answer to the question of how do we include more children, but I just want to say that I think it is a very important component that we've missed for a long time in viral hepatitis. In part because the complications of hepatitis are not usually seen mostly in children. It is like in early adulthood and later years in life. So we have not linked like what interventions do we need to do at this early ages to prevent some of these. And this is a missing gap that we need to look into, we need to work on, and we need to find ways to integrate this. And in terms of policy and financing, what we have found is that some of the other diseases get more attention than viral hepatitis because they account for mortality in under fives. So we dissociate preventing infection in children to preventing liver cancer in adulthood. So if this intervention does not reduce the under 5 mortalities, it's not prioritized. And that's how comes like hepatitis B and C financing and policy and like advocacy drops down significantly. So I think bringing children into the picture and showing that these interventions at that stage are important for the children and later in their lives could help with managing the sequelae and maybe bringing up hepatitis B agenda high up in the policy and financing discussions. Yeah.
Thank you. Any other comments?
Yeah, I mean, Robbie, I think it's so critical, and I think this is why, we're so glad to have you as the moderator here. And I think we'd love to hear your thoughts too. I think as a patient advocate, I've heard so many stories of children living with Hep B and the impact on their families, which I think is also very invisible. And I think when we talk about stigma, shame, discrimination, it is so acute and heavy when you're a child because it affects the kid in their school, the daycare, the nanny, the parents are worried. As young adults, they worry about, sexual transmission and their careers. Like it impacts them their entire life besides just this liver cancer that we worry about, towards the end. So we do need a lot more research studies and treatment and care for people at that age. I've heard you talk about this, so I feel like it'd be great to hear your views on this and how they've changed, because I think it's important for all of us to be more aware and really start earlier, right? With all this stuff. Yeah.
Yeah, I appreciate you saying that, Sue. And I do, you and I have talked about the idea of treatment as prevention overall, and that we don't think about it as much in children, but it very much is still the case where with obviously thinking about the research of a longer life timeline, being on treatment, and the hope that at some point within the next 10 years, 10 to 20 years, we'll actually have some kind of cure for hepatitis B. But changing our time frame for treatment, simplifying the algorithms, and really sticking to those, I think there's been research out there that even pediatric hepatitis B specialists don't treat enough patients, even though they made these criteria about who should be treated, and they still don't necessarily follow them. And so I think we need to break down some of these barriers and embrace sort of the treatment for all approach, knowing that kids with hepatitis B, are much more likely to be in that very high viral load. Even if they're called immune tolerant, there's still the opportunity for cancer formation at any point early in life. And so we've talked about reframing, and so I think it's reframing in so many ways. I know we're up against the last few minutes. I wanted to hit maybe one or two points before we close. Gibril, you mentioned hepatitis B birth dose in your presentation, which I really appreciated. And, it has such an incredible track record, and it's been such an integral part of hepatitis B prevention across most of the world, but Africa has really been largely left out of this. Birth dose is not available in most countries. So, and I love the way you talked about how people are trying to change that with some innovative new products. But what about other ways to implement, whether it's cold chain, whether it's better local delivery, engaging things like Amazon? Like, how can we do better when it comes to birth dose, particularly in Africa?
I think that most of the barriers to timely birth administration in Africa now are more just us not leveraging the existing platforms to be able to deliver these. We still see all vaccines, or in most places, as like the problem of the EPI program, and those are usually structured like around rigid schedules. In areas where there's cold chain, they would have immunization days. In areas where they do not, they will have tracking clinics where a team would come for a day to administer vaccines. And this works for most of the EPI vaccines. It just doesn't work for the birth dose. The vaccine itself is thermostable. It can be left at room temperature for a while and it's still safe. We have formulations where we are not worried about wastage, so you can open a vial and can be used over a period. So I think the most practical, realistic way to overcome most of these barriers is to integrate the hepatitis B within the maternal platform. Those who deliver the babies should also administer the vaccine as part of the immediate neonatal care of the infants, and that overcomes most of this. Currently, we've seen in most African countries now, up to 80 to 90% of women are giving birth in facilities. If we are able to target these women and administer the vaccine to all those infants, we would already start hitting the WHO goals. And then we worry about the remaining 20 or so who are still giving birth in communities and looking for innovative ways. And that's where innovation comes in. How do we then target those? But we already have low-hanging fruits. Women are coming to the facility, so make sure the vaccine is available there. And most of the excuses don't really apply to hepatitis B vaccination.
Yeah, thanks so much. Any other comments? All right, we've got about 5 minutes left. Many of you touched on the idea of treatment simplification and bringing treatment decisions to physicians, nurses, other trained healthcare providers at the front line. So I'm going to ask the question, and people are going to not be happy, but AI infiltrates every conversation we have. But is there room for some kind of AI-powered solution, perhaps clinical decision support or something that could be accessed on your cell phone, even in the remote parts of the world, that could help with perhaps the simple treatment decisions, knowing that certain patients may still need more advanced specialist input? Can you guys talk about what kind of AI role might be available in different parts of the world for different needs?
I mean, I can start, but yeah, we're all afraid of AI, but we have to embrace it. I think we get told that all the time. So, I mean, there are things we can do with it. I mean, I like the idea of using AI in decision support tools, so helping, decide on. I mean, you can use them in mobile platforms, etc., and decide, especially on treatment decisions for hepatitis B. While it's still so complex, I hope that gets easier over time. But it helps with remote, in clinical support in very remote settings. So feasibly, that also encompasses task shifting, obviously, and having literally those decisions could be made right in that community at the point of care on that same day about a treatment, whether to do treatment or not. Obviously that would need to be integrated with some testing as well. And I guess you could use your AI for interpreting test results. I could see AI being used for, haven't really thought too much about it, but helping with, getting patients navigated into care. I'm sure there are systems already in place like that. And then with some supply chain issues as well. But I'll hand over to others. They may have more thoughts on this.
Yeah, I think I think it's got so many benefits in terms of democratizing information, right, and access to remote areas. And there are apps already out there. And there's one that Patrick Kennedy has called Hep B and Me, which is really brings those algorithms to the patient and the physician. HepBCommunity.org is a forum for patients, also with physicians, and they're building in some AI, like almost like a chat bot where you put in your results and then it uses reputable, references to give people like interpretation of their results. So I think this is really going to actually help. I think obviously we want to make sure people are referencing the right things. But like you mentioned, like we really need to revolutionize access to care and think about it as everybody is eligible for treatment. Some people it will benefit less than others, but rather than thinking, that people have to meet the strict laboratory-based criteria, that we really have to change our framework of thinking, who do we not treat, right? We think there are so many benefits you talked about. Now we know the science behind integration of the virus into the liver cells, where you don't have to be cirrhotic for Hep B to develop cancer. And that's critical for patients to know that that starting early, treatment early can help prevent those integrations. So I think, AI is a great tool.
I'll just jump in for 30 seconds. I think beyond leveraging AI for access to care, I see its potential use in liver cancer surveillance programs as well. And we mostly rely on ultrasound scans because they're cheaper, they're more accessible, but you get very discrepant results based on who's doing them. So integrating AI there to help standardize that and to be able to pick up early cancer cases that can then be referred for curative therapy would be a game changer, I think.
All right. Fantastic. All right. Well, that's going to close out our panel discussion. I appreciate everyone's participation and thoughtful answers. There's a few questions that are open that if I could ask perhaps Sue and Nida to take a look at. I think you can chime in with your thoughts. And then I'm going to pass it to Arik to close out the session.
Yeah, I think for the last one is talking about empowering communities. I just want to encourage, if you're in a country or somewhere where you're looking to connect with community, to reach out to the World Hepatitis Alliance or the Hep B Foundation, because we're in touch with many people living with hepatitis B all over the world. And I think it's great that people want to partner.
Thank you. Apologies, I lost the ability to control my own computer here, but I wanted to go ahead and thank everyone for, we'll stop sharing, see if that fixes our problem here. But thank you so much for joining the panel today. I know that, our moderator, Dr. Javari, our guests, Dr. Hawkins, Dr. Ndow, Dr. Wang, and Dr. Ali, your expertise and insights have been so valuable. And I think what we've heard in today's discussion, it's just really reminded us that we have the tools to eliminate viral hepatitis and achieve these 2030 goals, but it is going to take a stronger political commitment and equitable access to care and a lot of sustained partnerships between the people that we've talked about, whether it's governments, healthcare systems, civil society, or international organizations. But success is really going to depend on turning this evidence into action and continuing to work together across all sectors. Before we close, I just wanted to ask for your support with one final opportunity to contribute. I don't have the image here to share with you at the moment, but I will send it out as part of our follow-up email with the recording of this session. But the PentaHep Working Group is conducting a brief survey on the management of chronic hepatitis B in children, adolescents, and young people. The survey is going to help inform future pediatric hepatitis B research and improving our understanding of current clinical practices around the world. So if this applies to your work or if you know somebody in this space, we encourage you to complete the survey. Again, the QR code and the link to the survey itself will come out in the wrap-up email with a recording of today's session. So again, thank you to our speakers and to everyone who joined us today. We hope this conversation continues to inspire your collaboration and your meaningful action towards hepatitis elimination. We wish you a pleasant day and enjoy the rest of your high-level political forum. Thank you very much.